So, tendinopathy. I think we can all agree that we've moved away from this sort of inflammatory-based process, obviously ignoring your like inflammatory arthropathies. And if you look at some of the work done by Jill Cook and colleague, they've sort of now established this continuum. So we're saying it actually keeps going around in a circle. We've got sort of 3 phases. And the first is the reactive phase, and it's almost like, going off subject quickly, actually I haven't got time to do that, so Martin's looked at all our talks and put them all together, because we're all talking now about managing load, and we're all given different ways in which we explain the patients. And I've basically used the work from Simon Spooner talking about the zone of optimum stress. And what we're saying is, has this got a pointer? Is that if we take any tissue, for example, it has this zone of optimum stress in where you can operate in that region, and in theory you won't get any injuries. And as Ian's already alluded to, if you don't put enough stress through something, then things will get weaker, so your risk of getting injury is higher. And then if we take our runners, for example, they may have decided, they say, good Christmas, as Ian said, done too much too soon, and they popped them outside of that zone of optimum stress, and then they start picking up injuries. And if they keep on doing that, then you get to a point where this window just gets smaller and smaller and smaller, to the point where they're just walking around day to day and they keep aggravating everything. So then if they continue to do that, then actually we then start to see physical changes within the tendon. And if you manage that first stage properly, you can reverse all the whole process. Whereas if you continue to overload it, you start to see structural changes within the tendon, you start to see some increased vascularity, which we know can be linked towards pain. And then we move on to sort of our weekend warriors, where they've had a grumbly tendon for years, they've carried on battling through, they keep doing it, everything gets thickened, it gets nasty, it gets horrible. We've all seen mid-portion Achilles that you look and they're about 2-3 centimetres thicker than they should be. If you've ever been in surgery, if you look at a stage 4 tib post tendon under the knife, it's a lot thicker than it should be, and we know there's an increased risk of rupture. But this is where the continuum comes in, is because actually you then can get reactive on degenerative. So you can get an acute flare-up on an old problem, and I think it's safe to say in the room that's actually what we see the most of. So then it goes on back to, okay, how do we rehab this? And there's sort of 2 phases to rehab. In phase 1, we've got to reduce pain, and phase 2, you got to try and improve the strength. And actually there's a physio called Tom Goom, the running physio. He's got a great website, great blog, and he's got actually a nice little piece on his website, nice amount of references on there that you can go and read about this on there. And I like using the term edu-rep. So, and that means that we have to educate the patient, unload, and the key is unload, not rest. Again, going back to the whole zone of optimum stress, if you rest it completely, things get weaker. And then we got to reload it in a controlled fashion, but then progress it onwards to the activity they want to do. And there's some work by Sidbernagel looking at, he predominantly looks at Achilles, but it's looking at pain during rehabilitation. And he's sort of saying that if you get pain between 0 to 3, that's out of 10, that's your sort of green zone, that's okay. 4 to 5 is your amber zone, that's just about okay, but you're pushing the limits. Anything 5 or greater during or up to 48 hours after activity is a sign that you're aggravating it. So then you need to go back, manage your exercises, manage the load you're putting through that tendon to get them back, ideally within that 0 to 3. Obviously, we've got some patients where their perception of pain is completely different, and as Emma and Ian have both alluded to, when you start looking at clinical flags, this plays a massive part in things as well. So then you start looking at phase 1, reducing pain in this reactive / early disrepair stage. Now, as it's a continuum, there's no clear cutoff. One start, one doesn't end. Because it's a continuum, they all mold into one. So, and here you just got to educate the patient and just say, look, we take one thing at a time, keep it simple. And you've got to try and reduce pain to try and increase compliance. If they don't go in and do what you ask, they're never going to get any better. And it's explained to the patients that actually we don't fix people. They will do it themselves. We just got to help them along the way. And there are some exercises called isometrics, so static holds. There is some evidence, okay, that it was only a study using 6 people, and I believe it was in patellofemoral issues, but they're saying that using isometrics can help reduce tendon pain. But the key thing is reducing those compressive and tensile loads. Hence why if you've got an insertional Achilles tendinopathy, you don't do a heel drop because you add a compressive load to the insertion at the base of the calcaneum. Then we can then move on to your sort of late disrepair degeneration stage. Now, with this stage, you can explain to a patient that the road to rehab isn't linear. It's a mess. They'll have good days, they'll have bad days. One day they'll flare things up, next days they'll make good inroads. So you've got to find out what really aggravates it for them. And then when you start talking about exercises here, you can start thinking about eccentrics, so lengthening, concentrics, shortening. You can do a mix of both. You can do things called heavy slow loading. And in your handouts, I believe there'll be all the research articles I've put in there to give some evidence about using each one of those. But then it's important to think about a phased return to activity. So again, if they've taken 3 months off to go through this tendon rehab process, the worst thing they can do is then on day 1 get them back to running, go run 10 miles again, because then it's going to go back to square one again and they're not going to be a happy bunny. But before you jump into rehab, there's a few things that you need to consider. Again, is it appropriate for that patient? If you've got 94-year-old Doris with stage 4 tib post tendon dysfunction, nasty midfoot OA, are you really going to get her hopping around? I don't think so. And you then want to then take into consideration social factors, the flag system, as Emma and other speakers have alluded to already. But the big thing is just use the analogy KISS. Keep it simple, stupid. Don't overload your patients with information. Use technology. There are plenty of apps out there that you can monitor what your patients are doing when they're using their exercises, and you can communicate with them. And I'm not a fan of saying giving everyone do 10 reps and 3 sets and blah, blah, blah. Work to what they call your rate of perceived excursion. So 0 is no effort, 10's maximal effort. I like my patients to be working around that sort of 7 out of 10 marker, so find out what works for them. And then when you come to actually give the exercise, use the American College of Sports Medicine principles of FIT VP. And as long as you follow the principles up there, get out the way a little, you can then find out, okay, how I'm going to give an exercise, how am I going to progress, and you've got all your boxes ticked, really. So, tib post. Let's say take a reactive tib post tendinopathy. One is educate, and everyone's been saying that we need to educate patients about managing load, about managing their pathology, what they're doing that's really aggravating factors. And then we need to try and help reduce pain. And you can start possibly using isometrics. So for tib post, just a plantar flexion and inversion, and that's just my foot pushing against a dining room table. And then you can use things around the house, build it into their day-to-day life. Can they do their exercises while they're brushing their teeth, making a cup of tea, cooking their dinner, whatever? Because if you give someone a load of exercises to do at the end of the day, we're all massively time poor. They're not going to do it. You're not going to get the compliance. They're going to get despondent because they're not getting better. So then, once you've got the pain under control, then you can then start moving on to strengthening it back up. And this is where you can start to be really inventive. And this is where your anatomy, again, comes into consideration, because as long as you think, okay, what's a structure I want to strengthen, what does that structure do, then you can devise exercises to try and help it. So in tib post, you may want to start using some tone loop exercises. You may want to start doing some single leg heel raises. You may want to start doing some hopping, especially if they're playing a lot of sports like football, hockey, where there's a lot of cutting or change of direction, and start looking to integrate some plyometrics and some cutting work into their rehab. So just to finish off really, I think the take-home message is educate patients about managing load, reduce the pain first, and then build up the strength. Don't overload your patients, and if you get stuck, it can all be sorted out of a kiss. Thank you.
Thanks very much, Nick.